Welcome to the second annual Getzen Government Accountability Lecture. I'm Tom Loth, Dean of the School of Public and International Affairs. This lecture series is co-sponsored by the School of Public and International Affairs and the Department of Public Administration and Policy. Before introducing our speaker, I want to recognize Professor and Mrs. Forrest Getzen sitting down here in front, for whom the lecture is named. And I want to recognize Katherine Getzen Willoughby and Dan H. Willoughby, whose generosity makes this event possible. So Katherine and Dan and Mr. and Mrs. Getzen, if you'd stand up, we'd like to recognize you. Dr. Alice M. Rivlin is director of the Greater Washington Research Program and a senior fellow in the Economic Studies program at the Brookings Institution, as well as visiting professor in the Public Policy Institute at Georgetown University. She was the founding director of the U.S. Congressional Budget Office, 1975, director of the White House Office of Management and Budget in the Clinton administration. She served as vice chair of the Board of Governors of the Federal Reserve Board, chair of the District of Columbia Financial Management Assistant Authority. She's past president of the American Economic Association, recipient of the Elliott L. Richardson Prize for Excellence in Public Service, and currently a member of the board of directors of the New York Stock Exchange. She's the author or editor of approximately 20 books, including, among my favorites, Restoring Fiscal Sanity, How to Balance the Budget, Reviving the American Dream, The Economy, the States, and the Federal Government, and then Systematic Thinking for Social Action, all of these by the Brookings Institution. Her most recent book, with the ink barely dry, Restoring Fiscal Sanity, The Health Spending Challenge, published this year by the Brookings Institution. Dr. Rivlin earned the BA at Bryn Mawr and the MA and PhD at Radcliffe College, Harvard University. Her lecture this afternoon is entitled Facing Up to the Fiscal Challenge of Healthcare Spending. There'll be a reception for all of the attendees following the lecture over in Moore College. Please join me in welcoming to the University of Georgia, Alice Rivlin.
Thank you, Tom, and thanks to the Getzen and Willoughby families for providing this occasion. I am honored and delighted to present this lecture on government accountability and to get a chance to visit the University of Georgia, which I've heard about all my life and never been here. I don't know why, but here I am finally. And to get a chance to advertise the new book, which I will proudly hold up here. It actually isn't even published yet, but I called our press. The publication date is March 15th, and I called the press and said, do you have any copies yet? I'm going down to Georgia to give a lecture, and I'd just love to have one to wave around. And they said, oh yeah, okay. So the Getzen Lecture is about government accountability. Wonderful subject, I think. And that suggests that I'm going to talk about how we ensure that we get our money's worth for the taxes we pay. How do we measure what government is actually doing to improve people's lives and make sure that we're getting as much improvement as possible for the public dollar? Today I want to both broaden and narrow the topic. First, I want to narrow it to healthcare spending, which I think is one of the largest, fastest growing items in the federal budget, I know it is, and also in state budgets, including the state of Georgia. And I'll try to scare you just a little bit by pointing out that if federal spending for health care continues on the track that it's on, growing at recent rates, it'll just take over the federal budget. If the promises made to beneficiaries of the two major programs, Medicare and Medicaid, are kept in accordance with the laws now on the books, by not too long from now, sometime in the 2040s, we will be spending more on just those two programs than the current tax system will produce in revenues. Now, that's probably not going to happen, but it's an illustration of the difficulty of the problem. And that projection implies very painful choices. Either we will have to raise taxes a lot, or we'll have to virtually close down the rest of the government, or we'll have to break promises that have been made, most of them to senior citizens, or find some combination of the above. Unless we can find ways to slow the growth of spending because we're spending health dollars more efficiently. Now, those are really tough options. I mean, we need to understand why this spending is going up so fast, what we can do to slow it down, and to make the hard choices a little bit easier. But I also want to broaden the topic, because once you start into this subject of thinking about how to control government spending for health care, you realize you can't stop there. You have to think about the whole health system, not just the piece of it that's financed by the government or by multiple levels of government. Conceptually, it wouldn't be hard to figure out how to reduce future government spending for health care. We could just slash the benefits under Medicare and Medicaid enough to fit the spending to the revenues that are expected to be available. But that doesn't help. It just shifts the cost of future medical care more and more onto the states, onto employers, onto local communities, and onto individuals. The problem isn't that just that health spending is on the track to dominate the federal budget. It's on a track to dominate all of our budgets if we don't do something to alter the course we're on. Now, since medical care is getting more effective as well as more expensive, and we're all living longer, Americans are faced with these three interrelated questions. How much medical care do we really need? How are we going to pay for it, whether publicly or privately? And how are we going to make sure that we're getting our money's worth? And I'm going to try to focus on the money's worth part. Now, I think most people who start talking about health care talk about how to reform the whole system. Do we need a single payer system? Do we need to go to much more consumer oriented health plans? And I'll touch on that. But whatever we do, we're going to need to use the healthcare dollar more effectively. And from a federal point of view, the question isn't just how do we use the federal dollar more effectively, but how do we use the federal programs to make the whole health system more accountable to whoever it is who's paying for health care. That's what we wrote the book about, and I'll try to give you a little flavor of it, but not so much that you won't buy the book. Now, if you think that there's some easy answers to this question, I would invite you to leave now, because there really aren't. And that's what I'm going to emphasize this afternoon. Unfortunately, I think the healthcare dilemma, how to pay for healthcare, the healthcare we want, and how to produce it efficiently, is the biggest public policy issue that America is going to be facing, at least in the domestic arena, over the next several decades, and indeed in the foreseeable future. This generation of young Georgians will be dealing with the question for the rest of your lives. Now, that's kind of sounds like a life sentence, but the healthcare dilemma isn't the kind of public policy issue that just gets solved once and for all. There are public issues like that. For example, we built the interstate highway system. There might have been better ways to do it, but we did it, and it works pretty well. Nothing like that is ever quite finished, but now we're really worrying about how to keep it in repair and what to do about on and off ramps and occasional extensions, but the basic decisions are over and done and can't be unmade. Social Security is another issue that I think would not be hard to solve and put behind us. Indeed, about 25 years ago, we thought we'd done that. But then people began living longer, and now we have a system that's on track to cost considerably more than the revenues we're currently dedicating to it, unless we do something to fix it. But there are ways to fix it. In fact, they're rather simple ways, by either making the benefits less generous in the future or financing it differently. It's only money. It's not as complicated as the healthcare system. Now, liberals and conservatives have different approaches to Social Security, but if we put a group of people of divergent views in a room and said, you gotta solve this problem, they'd probably solve it by some combination of benefit cuts and revenue increases in a couple of hours. And then they'd have to write this into law. But then we could say, okay, we fixed that. And we could put it aside for another generation or so. But healthcare is much more complex. It involves moral issues, it involves rapidly changing technology, and it's probably not going to be solved, it's just going to be mitigated. And that's why I expect that the children and grandchildren of the young people in this audience will still be dealing with this question by the time they become voters and policymakers. Now, the problem's hard, but it arises out of two types of very good news, and I don't think we should ever forget that. Every year, researchers know more and more about how the human body works. They're able to intervene in increasingly effective ways. Research conquered infectious diseases, diseases of malnutrition and bad sanitation, at least in developed countries. Life-threatening diseases such as cancer and heart disease and diabetes and even AIDS are rapidly becoming chronic conditions to be managed over fairly long periods of normal and often very productive life. New drugs, new diagnostic techniques and therapies are just producing astonishing results. And the new frontier, as you all know, is gene therapy and very individualized treatment based on what kind of genes you have. But new therapies and drugs and equipment are almost always more expensive. The other piece of good news, of course, is that partly as a result of all of this medical success, but only partly, people are living longer and older people consume more medical care. And it's the intersection of these successes that produces the health policy dilemma that we're talking about today. And what makes health hard is that it just can't be treated like any other commodity or service. You can't really just say, okay, let the market do it. We don't worry about the rising cost of cups of coffee or other kinds of ordinary commodities and what to do about them. We let the market handle that by and large. But healthcare has a moral dimension. We don't want to leave people without it, at least in extreme circumstances. And it has unpredictable peaks, which means that people don't want to treat it like an ordinary commodity. They want to be covered by insurance, at least for large unexpected expenditures, lest they be left without needed care. That's all sounds sort of obvious, but it is the crux of the problem. If you have insurance that is covering you, whether it's public insurance or private insurance, neither you nor your doctor or other provider has much of an incentive to economize. So that's the crux of the problem. Now, I got into this problem as a federal budgeteer. I've spent a good part of a rather long career working on the federal budget. I believe we ought to balance it most of the time. Dave Walker, who gave this lecture a year ago, is very good at articulating the case for fiscal responsibility. We don't have to balance every year. There are times when it's appropriate to run a deficit, but over the long haul, we ought to pay for the services that we are asking our government to produce and not pass the costs on to future taxpayers. Every year that we spend more than we are collecting in taxes, the government has to borrow the difference, and this annual borrowing adds to the federal debt, the debt for which future taxpayers are responsible. There are lots of downsides to a country running up debt, just as there are for individuals who consistently spend more than they earn and run up their credit card debt. There's paying the interest, and interest is now among the most rapidly rising parts of our federal budget. There's the fact that government borrowing puts upward pressure on everybody else's interest rates, and that discourages the investment that we need to make the economy grow, and it makes it more expensive for everybody to buy a house or a car. And there's the basic fact that owing a lot of money makes us vulnerable. The U.S. at the moment owes a lot to foreigners, and although they have an interest in continuing to lend to us, they might not, and that's nervous-making. Now, skeptics will tell you that the current deficits are not off the charts, which is true. We've run higher deficits as a percent of our national economy. But that would be a relevant fact if they were temporary. If they were sort of smallish and we've been there before and we could see them going away, we wouldn't be so worried. But that's not the situation we are in. In fact, the deficits are projected to be much bigger in the future than they are now. Deficit projections, of course, depend on assumptions about the economy and about taxes and revenues. But if you make a set of pretty reasonable assumptions, what you see is that even if the war in Iraq winds down and other domestic programs other than Medicare and Medicaid and Social Security don't go up faster than the economy is growing, even under those assumptions, the federal deficit will rise very, very rapidly in the future, basically because of three programs. Social Security, Medicare, and Medicaid, but really because of the last two, which is how we got into this conversation. The federal budget problem is mostly a health care problem. Now, the three programs, Social Security, Medicare, and Medicaid, have in common that they are mostly promises made to senior citizens. Their spending is dominated by that. All three are entitlement programs, meaning that eligibility and benefits and contributions are specified in the law, and people draw benefits because they fit the definition of who is eligible. But Social Security, as I said earlier, is really the smallest part of the problem and the most easily fixable. We're spending less now than the revenues that are coming in, but that's going to change very, very rapidly. As the baby boomers begin to retire, spending will exceed the revenues, and we have to adjust the benefits or the revenues or both to fill the gap. But after the boomers are all retired, spending will grow more slowly, and only because of increasing longevity. Spending for Social Security now is about 4% of our whole economy, 4% of the GDP, and it'll level off at more or less 6% of the GDP. So that doesn't sound like a really hard problem. But let's come to the really hard problems. They are Medicare and Medicaid. Medicare provides, as you all know, health benefits for seniors and the disabled. Medicaid you may think of as a program for low-income people, but it is also dominated by the elderly and the disabled, just because they're more expensive. Taking care of low-income children isn't very expensive because most children aren't sick. The few of them that are generally have things that can be pretty easily fixed. But while only 25% of the population of Medicaid recipients are elderly and disabled, they account for 70% of the spending, which is actually not surprising. So the projected spending growth for these two programs reflects more than the aging of the population. It does reflect the aging of the population, but it reflects more than that. A far more important factor is the growing cost of providing the promised benefits. The cost per beneficiary is going up, and it's the rising cost per beneficiary, not the rising number of beneficiaries, that is really difficult. Now, this reflects the fact that healthcare spending per capita for all of us is going up faster than our income. For the last 40 years, which is actually quite a long time, the health spending nationally and at the federal level has gone up about 2.5% faster than the growth of our economy, the growth of GDP. And it's been a little faster than that relative to GDP in the last few years. So the government spending just reflects this general phenomenon that spending is rising per capita, per beneficiary, per anything, faster than incomes are rising. The rate of growth of federal revenue is at constant tax rates, just about what the rate at which the economy grows. So what we're saying here is the cost of these programs is growing faster than federal revenue. Or if you're an individual, the cost of your health is growing faster on the average than your income. So the federal budget crisis is primarily a healthcare crisis. But that's just the federal perspective. Healthcare spending is projected to rise as a percent of all spending and to loom larger in the budgets of states and localities and businesses and individuals. And we're on the high end of other countries already. We are already spending almost 17% of our total resources on health care. It's gone up pretty rapidly. It was less than 10% in 1980. And the Council of Economic Advisors, which is not a wild and crazy bunch, projects that by 2015, which isn't very long from now, we will be spending 20% of our GDP on health care, and that this percentage will continue rising. Now, by 2015, students who are now at the University of Georgia will be earners and taxpayers. And what this says is that 1 out of every $5 that they earn will go on the average for health care, either publicly or privately. Moreover, the worrisome part is it's not clear that we're spending all this money wisely. We devote a higher percentage of our total resources to health care than other advanced countries. The average for the OECD countries, which are advanced countries with incomes more or less like us, is about 9% as compared to our 17%. And Canada is about 10%. The Western European countries range, but they're in that sort of around 10%. which is quite different from 17 going to 20. And it's not obvious that they are less healthy. In fact, in general, their health outcomes are a little better. They live a little longer, and other indicators like infant mortality are better for them than they are for us. And then there's the problem that 46 million Americans aren't insured at all. That doesn't mean they don't get care. They do when they're really sick, but they get it in an expensive way, mostly through emergency rooms. And there's very interesting and growing body of evidence that the healthcare delivery system is inefficient and wasteful in many respects. Professor Wenberg at Dartmouth has, and a whole group of people around him, have been mining the Medicare data for years and have come up with some fabulously interesting statistics about the difference in treatment of specified diagnoses in different parts of the country and among different providers. If you live in Miami and you have a heart attack or hip replacement or several other quite specific things, it costs about twice as much as it does if you live in Minneapolis. And the results aren't any better. So we have really quite a lot of evidence that if we were doing in some places and in some provider situations, some hospitals particularly, what the best ones are doing, that we could cut spending quite a lot. Now, so we're not just dealing with a federal problem or even a federal state problem. And cutting these Medicare and Medicaid benefits or restricting eligibility would certainly help the federal burden, but it would shift the burden without in any way changing this quite inefficient system that we have or slowing the growth of total spending. And therefore, the most important question is not really how to cut the federal budget spending, but how to use the federal budget programs, the federal health programs, to move the rest of the system or the whole system into more effective channels. And that's what we tried to write the book about. Now, I've been surprised as I've talked about this to various people that many people seem to think that there's really a silver bullet here, and they're always sure they know what it is, but they differ. One is if we only had better information technology in the health system, we could solve this problem. And you all know, if you've been to a doctor recently, that the medical system, particularly doctors, but even in many cases hospitals, is behind the rest of the country in using information technology effectively. I've gotten into a very teasy relationship with my internist on this because she'll rifle through a sheaf of papers and then look at me somewhat befuddled and say, have you had your pneumonia shot? And I say, you shouldn't ask me that. It should be on your screen. And then she explains why this practice hasn't moved to get online yet. But this is not untypical. But the notion that this is some silver bullet that's going to change the whole system if only we could do it doesn't stand up to analysis. First place, it's expensive. There's a big investment up front, and not that we shouldn't do it. The beneficiaries are more likely to be patients and insurance companies than they are to be doctors, so we've got to somehow figure out how to get the incentives right. But the real reason this isn't as magical as it seems is that the ultimate benefits of having the information are from changing the way the practice operates, both in hospitals and in private doctors' offices, and that's going to be slow and difficult to change. Another favorite silver bullet is tort reform. People notice that there are huge judgments for a malpractice that run up the cost of malpractice insurance, which is indeed very expensive for certain specialties. And imagine that if we just did that, if we just had tort reform, this problem would go away. Well, I think we ought to have tort reform. This is part of the answer, as is health IT. But malpractice insurance premiums are 2% of the cost of total health care. So this isn't going to be your whole solution. Another favorite one, growing out of these differences in practice around the country, is if we just changed to pay for performance, then we could solve the problem. And that's partly right. We really do need to collect the information that will tell us what the best practice is and change reward systems so that they do reward effective practice and the best way of treating whatever the condition is. That's going to take a while. It's a very difficult problem. And Medicare so far has put a toe in the water. They have, in recent years, begun adding on a supplementary benefit for, or supplementary reimbursement for hospitals that meet certain criteria. Like they give you an aspirin when you first come in if you're complaining of your heart, and other things. And that's a step in the right direction. It's not a very big step, and it's not going to solve a very large part of the problem until we do a major investment in collecting the information and designing reimbursement systems that do move practice toward best practice, but best practice is always changing. And there are other magic bullets. Curbing drug profits, yes, that would help, but it's a little hard to know how we're going to pay for research if we curb them too much, so it's not an easy problem. Prevention and healthy lifestyles. If only we could get people to stop eating so much and stop smoking and exercise more, couldn't we solve this rising health cost problem? Well, again, it would help, but it is very difficult to get people to stop smoking and to lose weight, as anyone who's tried to do it knows. And there's this other problem. Us healthy seniors don't consume as much medical care every year, but we live longer. And the total cost of a regime in which everybody did the right things and didn't eat too much and didn't smoke and did exercise might not, in the end, be less. There's also a lot of focus on the last year of life. And clearly, a large fraction of expenditures do occur in the last year of life. You don't know when the last year of life is going to be. And it is difficult to design protocols that will reduce that very, very much. People need to give clearer instructions. Whole movement in terms of living wills is important. And the other is covering the uninsured. Clearly, if we could cover the uninsured, not just for humanitarian reasons, but for health reasons, the system would be in better shape. But it's not going to be free. There are lots of people who would then be able to get medical care who aren't getting it now, some of them would end up getting less expensive medical care because they would prevent things. But it's something of an illusion to think we can cover 46 million people and it's not going to cost anything. It was actually an illusion that the Clinton administration had. We thought we could make the system so much more efficient quickly that we could cover more people without rising cost. But I think people are sadder and wiser as a result of that experience. I don't want to knock any of those things. They're extremely important. We have to do all of them. But they illustrate that we're dealing with a really hard problem here, and I hope many of you get interested in it and really want to work out what the answers are. As to public policy strategies, there are basically two. One is to make the market work better, to rely on informing consumers, the theory being that consumers armed with reliable information about costs and outcomes of health providers will make more effective choices. They will shop for a better deal in the healthcare market. And providers will respond by improving the effectiveness of care and lowering cost. That is the philosophy behind setting up health savings accounts and allowing people to pay for their own health care. The notion that if they do that, rather than having the insurance company pay for it, they will make better choices and we'll get more cost-effective health care. But there are big limitations to that. No one suggests that we should just throw the market open. All of the consumer-oriented health plans are health savings accounts plus a high deductible insurance that says that if you have a really serious illness or catastrophic event, then of course you're going to be covered. But that's where the money is, unfortunately. Even if people make more cost-effective choices on small expenditures, the kind of daily routine things that when you get a sore throat or an earache, then they're still going to be covered for very large dollar expenditures, and that is where the real expenditure comes, or a very large part of it. So one is driven, I think, to another strategy, a regulatory strategy, to design administrative rules, whether within a public or a private system, that encourages provider performance and punishes non-performance and gets a more cost-effective health system going. Now, as a practical matter, this is not a choice. Any viable health reform must blend both strategies, although the emphasis might differ. And improved information about costs and outcomes is crucial to both, because whether you're relying on better informed consumers or relying on administrative pay for performance or effectiveness systems, you need the information to do it. So, having thought about these things for a while, what did our little group that produced this book suggest? A whole list of things, unfortunately, but I think we really have to do them all. What can the government do? Well, the government can collect and provide better clinical information. Medicare itself is a huge database that can be used with adjustments to give us more information on cost and outcomes of health treatments by diagnosis and provider. If we start with the Medicare database, we can add data from other insurers. But Medicare has almost got to take the lead on that. The government can sponsor cost effectiveness and comparative effectiveness studies of medical treatments. It can disseminate the results and sponsor best practice protocols. It can finance evidence development in Medicare, where one might say, here's a high-cost treatment. We aren't going to make it available to everyone, but we can make it available on an experimental basis and determine which groups of patients or what kinds of patients are most likely to benefit, so we know how to use it most effectively. We can improve the price setting. Medicare, as I said, has taken a timid step into the water, but over the next few years, we can change the way health providers are reimbursed through Medicare and through other programs. Medicare is so big that if it begins to change its provider reimbursement incentives, other payers will change too. And hospitals aren't going to bother, we know this historically, aren't going to bother segregating their patients. They're going to treat everybody alike, so that if Medicare can take the lead, it will impact the whole system. The government can use its market power, although this is very controversial, to negotiate for better deals, both with drug companies and for providers of other medical devices. It can use a bidding system and get prices down, although it can't get them too far down, or it will, again, kill the goose that laid the golden egg. It can develop standards for interoperable health IT for hospitals and for physicians and for other health providers. It can use the Veterans Health System as a laboratory to test improvements in health information technology, hardware and software, and design methods of using it to great advantage. The VA used to be a disaster. It's not anymore. It's on the forefront of doing cost-effective medical care. And it can provide incentives for or mandate the improvements in health information technology, including setting a date by which everybody would have to have a universal portable individual medical record that could be carried from one provider to another, so that everybody would know what everyone else was doing and errors would be minimized. It can improve the healthcare delivery system. It can incentivize lower cost treatment environments, such as hospice versus hospitals. It can sponsor studies to design more effective methods of treating high-cost patients. There are lots of things that the government can do to move this system toward more effectiveness. We could change some of the public policy that encourages low deductibles and low coinsurance under insurance, under private insurance policies. And President Bush just made an interesting step in this direction. In his State of the Union, which hasn't actually gotten a lot of favorable comment, he did a very bold thing. He said, let's make taxable, let's make employer contributions to health insurance taxable, and then give people a deduction for the health care if they buy health care. any family would get a $15,000 deduction from income tax under the Bush plan. Although if they had employer-based insurance where the employer was providing more than that, they would have to pay taxes on that, and their taxes would go up. But that's not true of most people. Most people would find that their taxes would go down, or their net cost would go down, if they got the $15,000 deduction, even if they had to pay for what their employer was adding to their income by providing health insurance. That's better tax policy than we've got now. Tax policy now just invites people to say to their employer, rather than a wage increase, just increase my health insurance, because then I don't have to pay taxes on it. And that's one of the reasons that we've gotten such generous health insurance in some industries where coverage is high. But that's mostly for higher income people. It doesn't help low income people at all. So what the Democrats could do if they wanted to meet the president halfway is say, that's a really good tax idea, but it doesn't help low income people because they don't pay enough income tax to get this deduction, and anyway it'd be fairer to make it a credit. But since they control the Congress, this conversation is quite a possible one. Let's imagine that the president says, here's my plan, and the Democrats say, well, we kind of like it, but we want to change it to make it a refundable tax credit so that it helps low-income people too. That would make it more expensive, but for the first time, we might have the basis of a serious conversation here. There are lots of other things that can be done, and I won't give you the whole long list. But I hope I've convinced you that, first, this problem is important to everybody's future lives. There are lots of things that can be done that are promising in terms of slowing the growth of healthcare spending, although none is a magic bullet. And the solutions will take hard work and intellectual effort, more than they'll take ideological posturing, but they'll be interesting careers for a lot of people coming out of public policy schools. Thank you.